Today, I want to talk about hCG and its role in testosterone therapy. If you've ever Googled this topic, sometimes it'll come up on two different extremes. I've seen where people are like, if you're on testosterone, you have to be on hCG because it's going to keep your testicles awake and prevent full HPTA shutdown. I've seen other stuff where it's like hCG is pointless, it does nothing. And of course, like usual, the truth is typically somewhere in the middle. And to make it even more confusing, hCG is actually the female pregnancy hormone, which sounds kind of crazy to want to inject this into a male body, but let's kind of dive in on what it is, what it's used for, and what to look out for. All right, Landon, hit the disclaimer. Quick sidebar, it was used a bit alongside a 500-calorie diet several years ago, the hCG diet. And surprise, it really wasn't the hCG causing more weight loss. They were having you do it alongside severe calorie restriction of 500 calories plus this hCG. And this ruined the accessibility of hCG as the FDA reclassified it as a biologic, made the price shoot up like 10x overnight. And now it's very difficult to get the regulations to compound it. And so there's no real cost-effective way to get hCG today. And it was all because of that crappy diet recommendation. So anyways, let's kind of break it down a little bit. How does it interact with testosterone therapy? What it does in the male body? What can it help with in terms of fertility, testicular function, sexual symptoms, and where people overpromise and oversell it. There's no hype, no fear-mongering, just physiology. hCG stands for human chorionic gonadotropin, and it's produced in large amounts during pregnancy by the placenta. But that's not actually the important part. What matters is hCG in the male body binds to the same receptors of luteinizing hormone. So in men, luteinizing hormone is a signal from the pituitary to the testicles that say, make testosterone. hCG activates that exact same hCG receptor on Leydig cells in the testes. So even though hCG isn't luteinizing hormone, functionally in the male body, it acts like luteinizing hormone. This has been well established in endocrinology for decades. hCG has even been used as a diagnostic and therapeutic agent in male hypogonadism long before modern TRT clinics existed. The key point is hCG is not female hormone therapy, it's an LH analog. To understand why hCG is even discussed alongside TRT, you need to understand what testosterone therapy does to the HPTA axis. And so normally the brain releases GnRH, and that tells the pituitary to release LH and FSH. The testes respond by producing testosterone and sperm. And so that's what you're getting at the end of that is testosterone and sperm. When you give exogenous testosterone, the brain sees plenty of testosterone floating around and says, mission accomplished, shut it down, you're killing it, I'm not going to give you any more resources for this. So LH drops, FSH drops, and most guys they're basically zero, and the testicles receive much less stimulation. Right now, we don't think this makes any long-term difference in overall health. It's an area that is being studied, especially since testosterone therapy is so much more commonplace these days. But what we do know is that intratesticular testosterone falls and sperm production declines on testosterone therapy. Testicular volume decreases in about 30% of guys. This happens even if the testosterone levels look great. And that is because the distinction, serum testosterone versus intratesticular testosterone, is critical and often misunderstood. But let's talk about where hCG fits into that metric. Because hCG activates the LH receptor directly, it can bypass the suppressed brain to testes signaling. So even though LH and FSH are undetectable, hCG comes in and binds to those Leydig cells in the testicles and gets them to start functioning again. So there's increase in intratesticular testosterone and maintains some testicular activity. There's a landmark human study where healthy men were given testosterone to suppress their natural axis, then given low-dose hCG. And the result was that intratesticular testosterone was maintained or even increased depending on the dose, despite complete suppression of endogenous LH. So that tells us a couple things. One, you don't need pituitary luteinizing hormone if you can provide a luteinizing hormone-like signal directly. And so I'd say the biggest reason that we put guys on hCG is to maintain testicular volume. Most guys don't care, but it can be negative to see the boys at a fraction of what they were. So it's not uncommon to see softer testes, reduced testicular volume. At the beginning, sometimes there's some testicular discomfort, but that's pretty rare. And there's no danger to this. It's typically just cosmetic, but it's a real side effect. And by providing this LH-like stimulation, hCG can keep those Leydig cells active, preserve more testicular volume, reduce that offline feeling that some men describe, and overall, sometimes it just helps you feel a little better. Is that guaranteed? No. Does it work for everybody? No. But it's a reasonable physiologic explanation why some men prefer TRT plus hCG over testosterone alone. So let's talk fertility. That is another spot that we will bring it in, is if you are on testosterone and you now want to get a sperm count back up, we'll bring in hCG. Sperm production requires FSH, follicle stimulating hormone, and higher intratesticular testosterone levels. Intratesticular testosterone, not serum testosterone. So when testosterone therapy suppresses LH and FSH, intratesticular testosterone drops, and spermatogenesis, where you make sperm, can decline significantly. hCG helps by increasing that intratesticular testosterone back up, supporting Sertoli cell function indirectly, and there are clinical studies that show that testosterone plus hCG can preserve semen parameters. Important word there is some. hCG is not a fertility guarantee. It's still very good, but some may still need FSH. FSH stimulates the Sertoli cells directly and are more sperm specific, but you're still going to need that hCG up front to help. Clomiphene or enclomiphene may also help if you're not on testosterone therapy. These are basically moot if you're on testosterone therapy. I did a much longer video over why these are not strong enough to overcome a suppressed axis on testosterone therapy. If you want a more deep dive, there's another video. hCG may help preserve fertility, but it's not foolproof. Another little kind of side caveat with hCG is that I've seen some people say it somewhat backfills the steroidogenesis pathway for like improving pregnenolone and DHEA levels. And, so that may have some use. What happens in the testes, LH or hCG activates CAMP, protein kinase A, and STAR, steroidogenic acute regulatory protein, and STAR moves cholesterol into the mitochondria. That allows cholesterol to go from cholesterol to pregnenolone, which I've done a video on this in the past, and this is kind of the mother of all hormones. This is the rate-limiting step of all steroid hormone productions. And so when LH is suppressed on TRT, testicular pregnenolone production drops, and so downstream androgen synthesis may drop a little bit locally. When the hCG is added, that cholesterol to pregnenolone step turns back on inside of the testes, and then from there, the Leydig cells can produce pregnenolone, progesterone, DHEA, and some of the intratesticular testosterone we talked about. The key nuance with this is that most of the serum pregnenolone and DHEA comes from the adrenal glands, not the testes. And so even if hCG increases the testicular steroid precursors, you may feel better, you may have intratesticular signaling, but not see major changes on serum labs. Both things can be true. What hCG does not do, hCG does not stimulate those adrenal glands. It does not fix adrenal insufficiency. It does not reliably raise serum pregnenolone or DHEA levels. So to kind of sum it up, the correct statement is hCG can support testicular steroidogenesis upstream, but not systemic adrenal hormone production. I want to talk about, we do use hCG at times for delayed orgasmia, and because some guys do report improved penis sensitivity and easier orgasm, somewhat of a less muted sexual response. And there's not tons of randomized control trial data on this, but this is just anecdotes from taking care of a lot of guys and also guys giving me their own feedback on it. This probably is related to improved intratesticular androgen signaling, probably some of the neurosteroid effects like DHA and pregnenolone. This is something some guys may experience, but it's not something I promise on every guy. But it is worth trialing, especially if you're struggling with delayed orgasmia or decreased penile sensitivity. Side effects associated with hCG, it's typically well tolerated, but what can happen is mood swings or irritability, headache, fluid retention, nipple sensitivity, and injection site discomfort. Overall, it's not a more is better drug. One of the last things I want to talk about is I don't really use hCG as a monotherapy. Whenever I'm if it's used as monotherapy, it is still suppressive to the HPTA axis, meaning it's going to be just like testosterone in that your body's going to pick it up that it has plenty of signal, and it's going to be suppressive to the LH and FSH signals. It's not just adding to them, it will shut them down as well. And there is literature that shows that it can be used as monotherapy, especially if they have secondary hypogonadism, if you're, trying to hit specific fertility parameters, if you're a young guy trying to avoid TRT. But again, I've still seen it suppressive. And so if I'm not doing testosterone and I'm putting on hCG, I typically would like a SERM in the background that they do have some utilization in keeping the HPTA axis awake. With hCG, it's just not as strong as testosterone. Overall, testosterone therapy is overall just more effective if we're, trying to consider monotherapy without the extra meds and potential side effects. But overall, the takeaway is hCG is not mandatory on testosterone therapy, but it's not useless. It's a tool, and for the right patient with the right goals, fertility, testicular function, symptom quality, it can be brought on. But it does need to be brought on thoughtfully, individually, without overselling. And so if someone is selling hCG as magic or dismissing it entirely, then they probably don't understand the actual physiology of the medication or what's going on in the body. So I know that's kind of a lot to just unpack real quick. If you have any further questions over it, feel free to reach out. Otherwise, stick around to the next one. Thanks.